The Wellness Hour. An in-depth discussion with today's top physicians and medical leaders. And now, your host, Randy Alvarez.
You're watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. Today's topic, what you need to know if you're considering any type of breast surgery. With us, we have a board-certified plastic surgeon, Dr. Robert Cohen. Dr. Cohen, welcome to the program.
Thank you so much for having me.
All right, now, before we get into today's topic, tell me a little bit about your practice. Who's your typical patient? I guess as a board-certified plastic surgeon, you do just about everything, but, you know.
Right. Well, I do a wide range of things, but I would definitely say breast and body surgery is one of my specialty focuses. And so my patients range anywhere from, early 20s, maybe even a little bit younger, rarely, probably most commonly in the late 20s to mid-30s to 40s. And then I see quite a few patients who are in their 50s, 60s, and sometimes even a little bit older than that for breast surgery.
Now, you're a young-looking guy, but I know you've done thousands of surgeries.
Right. I'm older than I look, and I get that.
You look about 10 years younger than you look.
I get asked that a lot by patients, but I always I think they're reassured when they come in. They've seen that I've had so much training and I've been in practice for I've been doing surgery of some kind since 1999.
Well, your before and after, by the way, collection on your website is extensive. Probably one of the most extensive I've seen.
I think so, and I'm constantly putting more and more photos on there. It takes a lot of time for me to load photos, so I'm always behind on that. But I think it's very important for patients to see not just a couple of your best photos ever, but to see a wide range of your work, so they really can evaluate what do your patients look like after surgery.
Are the patients getting younger and younger for breast surgery, or older and older?
I would say neither. I'd say, well, probably I'm seeing an expanding patient population where more and more people are interested in this type of surgery, whether they're younger or older.
So it's becoming more mainstreame.
Oh, absolutely. To be honest, it's not the stereotypical 25-year-old coming for a breast augmentation. You see a huge range of patients who are coming in. I'm happy to see patients in their 50s, 60s, even older coming into the office. As long as they're healthy and they have good reasons for why they want to do the surgery, I think they can really benefit and be very happy afterwards. Some people, I've seen patients in their mid to late 60s come in for a first-time breast augmentation just because they finally feel it's time for them to do something good for themselves.
Is breast surgery turned into the #1 procedure, or is it still lipo?
No, well, I think breast surgery is probably still the most common, but liposuction is a less dramatic surgery and it's got more limited applications, whereas breast surgery, there's a wide variety of problems, too small breast, drooping, too big of a breast, that you can correct with the surgery. So.
Now, what if, I don't pretend to know what you know, but it seems like a pretty straightforward procedure.
Yeah, that's a
But there's a lot of technique.
Yeah, well,
tell me about that.
I always find it funny when people say, "Oh, it's breast surgery is so easy." It's really deceptively difficult. I think it's not that hard to do a mediocre breast augmentation, but to do a very beautiful, natural-looking breast augmentation, it takes a lot of skill. And beyond that, I would say the majority of patients I see in my office don't just need a breast augmentation. A lot of them need lifts or something else done at the same time, or revision surgery. Those are extremely difficult surgeries. If you're not very experienced and comfortable with that surgery, you can have major problems.
So what are the categories of breast surgery that you do?
Well, I don't want to bore you because there's so many different angles to this surgery, but there's a huge array of breast surgery that I do depending on the problem. So the basic categories would be breast augmentation, where you're making a breast bigger. There's a breast augmentation with a lift, where you're making a breast fuller and then tightening or reshaping the breast. There's breast reduction surgery, where you're making a breast smaller if the breasts are heavy or causing back and shoulder and neck pain and are droopy. There's basically surgery to correct prior breast surgery, so I call that revision or corrective breast surgery, where you're fixing problems from prior surgeries. And then there's all the little detailed surgeries. There's surgeries to reduce the areola size, or if the nipples are inverted, to bring them out, or if the nipples stick out too far, you can set them back in a little bit. So there's a lot of little details that are done that I do to make the breast look as nice as possible, and it depends on what each patient's issue is.
Now, what about redos? People that, women, do you do a lot of that?
It's almost like a new category of surgery that's emerging. It didn't exist, 30 or 40 years ago before breast surgery really started like it is now. But these are some of the most difficult surgeries that I see.
Really?
Yeah, absolutely.
Seems like they'd be the easiest.
No, they're the hardest because there are patients who have come in. Sometimes they've had 5, 6, 7 prior surgeries, different surgeons, and they can have really significant problems that are very
Problems like what? When you say what? Scar tissue?
Well, there's a lot of very significant problems. It's usually either a situation where the skin is stretched out, or gotten too loose on the implant, or the pocket is not in the right place, so the implant can be too far towards the middle or too far out towards the side, or too low, and you can get this, what we call a double bubble, where you have this, this kind of unnatural looking breast. The bottom line is there's usually some kind of asymmetry or appearance that the patients are very unhappy with that doesn't look natural
Is it
anymore.
Hardening breasts? Is that what brings
that can be a problem? That can be a big problem too. It's called capsular contracture, where you get tightening of scar tissue around the breast.
You take care of that.
I do, and in a lot of cases, it's not just one problem. It's usually a combination of things that need to be fixed simultaneously. So,
if you had to say there's a favorite type of breast surgery,
you know, if I had to pick one favorite, I think it'd probably be breast reduction surgery is my favorite.
Oh, really?
Yeah. You know, the reason I love breast reduction so much is it does two things. One is it makes the breast look better because it makes the areola smaller. I'm shifting it without detaching it and moving it into the center of the breast, really rounding out and reshaping the breast. But number two, you're reducing the weight and positioning the breast in a better spot on the patient's chest, so it gives them very, very significant physical improvements: back pain, neck pain, shoulder pain, bra strap grooving, all these things that can be very...
So is it the happiest group of patients?
I would say, I mean, all my patients are really happy, but the breast reduction patients, they usually, even the day after surgery, they're like, wow, I just can't believe how good I feel.
Really?
You know, yeah. Especially the ones with the really big breasts. It's a huge, huge life changer for them. They can exercise, do things they weren't able to do before because the pain is better.
Okay, let's talk then about the augmentation.
Yeah.
Okay, because again, seems like a very straightforward procedure.
Right. You know, I mean, in some...
There's art to it?
There's absolutely art to it.
And not everybody's doing it the same way?
You know, there's lots of different ways to do it, and probably the thing that makes breast augmentation challenging is that you're trying to get symmetry and a really natural shape to the breast.
To match.
Yeah, so, you know, if you just put implants in really quickly, you can get them bigger, but, you know, I don't tell my patients, hey, you're going to look the same as you did before surgery, just bigger. You know, if they're already close to perfect before and they're just too small, sure. But most patients have some kind of significant asymmetry or other issue that needs to be addressed at the same time as making their breast bigger. In fact, I would say some patients, the going bigger part is almost secondary to the reshaping or improving the overall look of the breast.
But what about, you know, when I talked to a plastic surgeon that told me, Randy, here's the way it works with breast surgery. And he said that if you have unattractive small breast, you're just going to have unattractive big breast.
Yeah,
but you disagree with that.
I absolutely disagree.
But there's guys that say that.
Well, I respectfully disagree. And I think if you simply are putting implants in, then I think that's probably true, that you'll go from a smaller unattractive breast to a bigger unattractive breast. That's where the whole array of techniques come into play. Some breasts do need more than just implants. They need other tweaks or techniques to try to reshape them, you know, whether it's making the areola smaller or shifting the areola position or doing a lift of some kind or removing a little bit of tissue if it's bulky behind the areola, or who knows what. You know, every patient's breasts are very unique, and I have some patients where their two breasts could be two different people. You know, you have a patient where one side is a B cup and the other side is a D cup, and I have to somehow make them match, and that's where the challenge comes in.
You like these challenging cases?
I do. I know I wouldn't do it all day, every day. It'd be pretty tiring, but I do a lot of it. I do multiple cases like that every week.
Now, you told me on the telephone, and I like when guys think that they're really good at what they're doing, you know, and you said, I would challenge you, Randy, look at my website, because at that time I didn't look at your website.
Right.
And I would challenge you to find another doctor doing, another surgeon doing, you know, or has better work than I do.
Well, you know, I feel like, I would never say, oh, I'm the best surgeon, you know, ever, but I feel like the quality that I'm providing matches up to anybody else out there. Yeah, and when I know I have patients who come in, fly in from out of state, from other countries sometimes, and sometimes they'll tell me, I've literally looked at 100 websites, and your photos were my favorites, and that's why I chose you. So I feel
you're meticulous. I mean, sometimes you may take twice as long as another guy.
Yeah, I mean, if it's a complicated case, they can take many hours. You know, and it's not something I rush, and so I definitely would never win the contest of who the fastest surgeon is, but I do feel like the time and attention to detail pays off, and the patients appreciate it.
So over the muscle or under the muscle?
I almost always do what's called a partial submuscular placement of the implant, which means that the chest muscle, which runs like this, is covering the upper half and middle part of the implant, and it gives you a nicer slope in the upper chest and better looking cleavage in the middle, and that extra muscle coverage is going to give you a more natural look to the breast.
So what about the implants? I guess, you know, what's changed as far as implants in the last 10 years?
Yeah, well, you know, I think the implant technology keeps improving more and more. I almost always use what's called a cohesive silicone gel implant, which is a silicone shell on the outside and silicone fill on the inside, as opposed to the saline where it's a silicone on the outside and a saltwater fill on the inside. I find the silicone in general is going to give you a much softer, more natural looking.
Feels more like flesh, is that correct?
It feels a lot more like regular breast tissue. And the thinner tissues you have, or the less coverage you have over the implant naturally, the more important it is to have a softer implant, because you're going to feel that difference more and more through the skin.
Now, there's different types of implants, like higher projection, things like that.
Right, different profiles. You know, that has more to do with the patient's body and what their goals are at the end of surgery. So I have a wide array of implants in my operating room, and all the different sizes, lots of different profiles, and I'll use whatever I feel is going to give that patient the closest look to what they want after surgery. And different people's bodies are more conducive to different types of implants.
So do women come in knowing the size of implant they want nowadays?
Yeah, I have some patients that come in and they say, I want a 350, and they probably think that's what they want because maybe their friend had it, or they put a bag of rice in their bra that was 350 cc's that they thought looked good. But ultimately, I don't feel like you really know exactly what the implant's going to look like until it's in your body, under the muscle. It looks different.
Interesting. So what do you do?
So what I do is, obviously based on the natural width of the breast, it kind of limits the patient to a certain range of implant size. If you go too big or too small, you're going to have problems with stretching of the tissues or just an unnatural look. But within the range that they like, there's some variability. So when I'm in surgery, I have a very good starting idea of what I'm going to use, but then I use what are called sizers, which are basically exact replicas of the actual implant, but I put them in temporarily. I sit the patient up in the operating room, make adjustments, and try different sizes. I tell patients, if you're going to go buy some shoes, you wouldn't just put a pair on and walk out the door. You'd try some shoes on and see which ones you like the best, which ones look good but also feel comfortable on your foot, and it's the same thing. I make sure the implant looks good. I do it every surgery. I think it's just, sometimes you don't need to do a lot of sizers if you already have a good idea of what the patient needs, but some people
I've never heard this before, by the way.
Yeah, I think it's
do your buddies all do this?
Some of the surgeons that I know do, some don't, but I think for me, putting sizers, sitting them up, making adjustments, making sure everything looks as symmetrical and nice as possible gets me the most accurate results.
But prior to determining size, they're in your office, you try sizers, or you try something on first?
I don't. I generally, because I think, again, it could be a little misleading and difficult for patients to try something on because it may look different in the operating room and in their body. I generally like to have patients give me an idea visually of what look they're going for.
So they'll bring in a photo?
Yeah, they'll usually go through my website. I have so many, hundreds of photos on there. They'll find a few patients that they really like that have a somewhat similar body type to them, and they like the look. And then I tell them it's not just a science, it's an art form. So I'm trying to get you in the range of what you want to look like. I'm also taking into account your tissues, whether they're tight or loose, or whether you have asymmetries or other problems. And I'm trying to give you the best overall result that I can that's going to give you the most beautiful breast possible. And so there's always going to be some things that are not exact. It's an art form.
I've interviewed at least 75 plastic surgeons over the last 13 years, and none of them that I know of are doing sizers on every single patient.
Yeah.
But this is one of those meticulous things to get the right look, the right feel.
Yeah,
is that right?
It adds a little time to surgery. Sitting them up, making these adjustments, and it could certainly go faster if I just put the implants in place. But for me to feel really comfortable at the end of surgery, I want to know exactly what they're going to look like with the real implant in before I open that box. So I want to test them out with sizers. I just feel the patients deserve it.
Okay, now on these consults for breast, do they bring in their partners? Do you encourage that?
Absolutely. So sometimes they come by themselves, sometimes they come with a partner, and then I always encourage family support or partner support or whatever the situation is. For younger patients who are under 21, I always want parental or family involvement, so it's they know they're making a good decision, that they're going to have a lot of support after surgery.
Is this true? By the way, I talked to a few other guys that they say that many people regret not going a little bit bigger. What are your thoughts there?
I think that to a certain degree that's true. If you're kind of wavering between two sizes, you're probably going to be happier with a little bit fuller size because people get used to the breast and they end up feeling like, I'm happy with a little bit fuller size. But some patients definitely don't want to be big, and they're very happy being like a full B cup or a small C cup. And ultimately, the most important thing for me is a natural, aesthetic breast that fits the patient's body. So I think as long as they're staying within a range that fits those criteria, you can go a little bit bigger, a little bit smaller. But if you go too big or too small, that's where you're going to get a less natural looking breast, and you're not going to get as nice a result as you can.
And this may seem like an obvious question, but who should consider breast surgery?
Well,
who's the ideal candidate?
I guess the obvious answer is anybody who's really not happy with their breasts. So, if you are finding that you can't wear the clothes that you like, or you feel that you don't look good in a bikini, or you don't feel comfortable in the nude, or you have asymmetry, or something else is bothering you, and you're healthy, and surgery is something you're considering, then I think you'd be, in general, a good candidate to at least get a consultation about it.
Okay, incisions. Okay, so I have this right. So under the fold, in the nipple area, armpit, belly button, and I've heard, I'm more confused than ever. I don't know who to believe. What are your thoughts? I mean, what do you like to do for augmentation?
Well, I mean, there's different ways to do it. You can go, as you said, through multiple different access points, and there's not one wrong or right way. Each way has its own pros and cons. Personally, I generally use the areolar incision, which is a very fine line at the edge of the areola, which I think has some major advantages. Number one, the skin is very fine there, so it tends to heal with a very fine scar. Number two is that the collar junction of the areola and the breast skin tends to hide and blend that incision. Number three is it gives me very good access to the entire breast pocket, so I can be very accurate in my dissection, make sure the crease under the breast is really even. Yeah, because I feel like if you don't create a scar or any kind of tissue damage down here, you can, from the inside, create a nice smooth curve. So I really almost never see problems with bottoming out or the implants going too low, because I have very significant control from above. And then lastly, a lot of patients have one nipple that's a little bit higher or lower than the other, so I can make that incision halfway around the upper edge of the areola and take a little extra skin out, and I can actually make an adjustment in the nipple at the same time.
Interesting, match them up.
Yeah, and the thing people always worry about is sensation, and studies have been done that show that there's really no major difference in sensation to the nipples after going through the areola versus going under the breast versus going through the armpit. It's more it is right. It's more due to the size of the implant. If you go with a large implant, you're not, you can have some stretch on the nerve where the nerve comes out of the rib cage, and that is what tends to do
well,
most
what about
of the
this argument, though? Okay, friend of mine, plastic surgeon, says, Randy, if the most beautiful part of the breast is the nipple area, or the nipple, why would you touch it? Why not just go in the fold? What is your response to that?
A couple things. Number one,
maybe he doesn't know what to stitch.
Well,
you do.
I would argue that if you look at my before and after photos on the website, it's very difficult to see a lot of those incisions. Okay. Number two, all the advantages I talked about before. But lastly, if you're wearing a very small bikini and you're lying down with your arms behind your head, you might be able to see that under the breast scar. But if you have an areolar scar, that's never going to be visible unless you're completely in the nude. So for me, I find that's the most hidden scar.
Now, armpit. You don't like armpit at all?
Well, it's not.
Did they ever come in and say, "Doctor, I want the armpit"?
Very rarely, and I don't think there's anything wrong with that approach either. I just feel like you're working from a pretty long distance. You don't get that direct digital control, the ability to be able to feel the entire pocket, make sure everything's as smooth as you'd like. And the other thing is that, again, if you happen to be one of those unlucky patients that gets a more visible scar than you'd like, you raise your armpit up and your arm up and you're wearing a sleeveless dress, you can see that scar. So for me, and then the other thing is a lot of the surgery I do involves some kind of tightening around the areola or revisionary surgery in the future, and that incision doesn't give you any advantages. If you're already using an areolar incision, I can do a tightening around the areola. I can do a lot of other things at the same time without adding a lot of extra scars. Yeah.
Okay. And now let's move on to the next category. Okay, so we've got augmentation, lifts.
Yeah. So, talking about lifts, half the patients who come in saying they want breast augmentation these days, when I actually examine them in the exam room, they need a lift as well. And the problem is that after pregnancy, and we're seeing a lot more patients coming in having had kids, breasts tend to get droopy or they lose some of their elasticity. And now it's not just that they're too small, but they have overhang, or they can fail a pencil test, as they like to say, where you can stick a pencil under there and it doesn't move anywhere. So you have to correct not just the size of the breast, but you have to correct the shape at that point. And if you don't do the lift at the same time, you're going to have a breast that doesn't look very nice.
But what about incisions or scarring? I mean, isn't that the biggest fear?
That is the biggest fear, and that I tell patients it's generally unwarranted. The scars usually look really nice, and you're looking at the overall big picture. So you're trading off a scar for a massive improvement in shape, areola size improvement, position improvement in the areola. So you can create major changes in the overall appearance of the breast.
A lot of guys don't like to do these lifts. You do. Yeah. Why is that? Is it a trickier procedure, technically?
It's a very difficult procedure if you haven't done a lot of it, and even when you have done a lot of it, it's still tricky. But I do so many of these procedures, I'm extremely comfortable with them, and I can get some very nice results for patients who are very unhappy with their breast appearance. And after surgery,
what makes for a good breast, by the way, in your eye?
In my opinion, what makes for a good breast is
for a natural, augmentation lift.
You want to have a size. The size thing is probably the most variable as far as personal taste, but you want to make sure the size is in the range that the patient likes. You want to have a nice clean slope in the upper breast, nice roundness at the bottom, cleavage is nice and close together, but not so tight that it's touching or pushing together. A nipple that's appropriate sized, an areola that's appropriate sized and centered in the middle of the breast. So that's what really gives a nice appearance to a breast that.
But cleavage, can you really do much about cleavage?
You definitely can. I mean, adding the volume with an implant, and then in patients where they have droopy breasts, if you need a lift as well, can completely transform this area over here, because this is really the critical area.
Why do I get told you can't really do much about cleavage?
Well, I think there are some variations. So if somebody has very close breasts naturally or very wide breasts naturally, that will impact what their cleavage looks like at the end of surgery, but there are certainly things you can do to adjust or improve the cleavage. So if somebody has very wide space breasts, I'll tell them you may not get as close as some of the patients who are starting out close together, but I can certainly get you closer together where you're going to be happier after surgery.
So moving on to reductions.
Yeah.
What are the keys to a reduction surgery? And who's a candidate?
Okay. Breast reduction, as I was telling you before, is one of my favorite surgeries because it not only gives patients a huge improvement in the way their breasts look, but it also makes them feel a lot better. It can improve back, neck, shoulder pain.
Is it the toughest to do as far as your technical skills to make it look natural afterwards?
I wouldn't say it's the toughest surgery, but it's certainly very challenging. And you see a lot of breast reductions that are very mediocre or not very good looking because the surgeons are saying, well, this is to make you feel better. How the breasts look really isn't that important.
Really?
Yeah, because a lot of surgeons are doing this for insurance, and they just basically knock out another breast reduction. It's not worth their time or attention. For me, I take a breast reduction as seriously aesthetically as any other breast surgery that I do. So it's not just a matter of making the breasts smaller or making them lighter, it's a matter of making them look as nice as possible at the same time. So when patients come to me, it's not a one-size-fits-all breast reduction. I'm listening to them. Some people want to be a lot smaller, some people want to be a little bit smaller. And it's not, a reduction includes at the same time a lift. So you're not just making the breast smaller, you're making the breast higher in the chest.
So you can give them a rounder, perkier on a reduction.
Some of the most dramatic surgeries on my website will be found in the breast reduction section, where patients literally have these monstrous sized breasts that are hanging down towards their waist, and after surgery they have these youthful, perky breasts. Two things. One is that it'll make patients look younger in a lot of cases because they have breasts back up where they never were in some cases. I mean, literally, some of these patients have never known what it's like to have a breast that doesn't have a lot of overhang.
Is that right?
Yeah, and number two is that a lot of these patients look a lot slimmer and more athletic after surgery because they don't realize their breasts are hanging over a lot of their abdominal area, and it can make them look kind of heavy because the breasts are adding to the stomach. And as soon as you move the breast up here, all of a sudden now you have a defined abdomen and it lengthens their torso. They can go from looking kind of matronly or heavy to looking very fit and athletic or slim. A lot of patients who have the surgery, their friends will come up to them and say, hey, did you lose weight or you look good? And they don't know exactly what happened.
With reductions, what are the misconceptions with the patient population about it?
Well, I think one thing is that there's an age limit to breast reduction. So really, if you're healthy enough to have surgery, almost anybody is a candidate for breast
60s,
reduction.
70s?
I would say
that's young.
I would say 60s, 70s up if you're healthy enough, because this can have physical impact on your health. So if you can fix the breast, you're going to feel better and you're going to be healthier and able to exercise better. On the other end of the spectrum, some very young patients are candidates. If you're 16 or 17 and you're having tremendous shoulder or back pain, then you are a candidate as long as you have, obviously your parents involved. Certainly the majority of patients I see for breast reduction are probably in their 20s, 30s, and 40s, but that's one of the misconceptions. And number two, a big misconception is that we take the nipple off and stick it back on. People always worry about that. There is a surgery where you do that, but I can tell you I've never had to do that in practice.
Really?
Yeah, I always leave the nipple connected to the deeper tissue so that the blood supply is still attached and the nerves are still attached. And what I'm doing is I'm removing some of the surrounding skin and just shifting the nipple up. Just like you can pull your nipple around on your chest, if you're moving it, you can do the same thing surgically. You're just removing skin to inset it. So, although that technique is sometimes necessary, for certain patients, never had to do it. And I've done some very, very big breast reductions.
Now, where do surgeons differ on incisions on lifts? Is that pretty straightforward? You guys are all doing it the same way?
There's some variation, and probably the most common technique is what's called an anchor scar, where you have a scar that goes around the areola, a line that goes down the breast, and then a line under the breast. And then a lot of surgeons leave what's called a inferior pedicle, meaning that the breast tissue is maintained from below. Personally, I like to leave the tissue coming up from above because I find it gives you better fullness in the cleavage area and looks nicer.
So you don't or rarely use anchor?
The two, I guess I don't want to confuse you. The deeper tissue, whether it comes from above or below, is separate from what type of scar pattern you use. I would say that in a lot of cases I am able to avoid the anchor scar, avoid the under the breast scar by doing just a lollipop scar lift. And that was one of the things that I did the most of during my residency training was a vertical breast lift, breast reduction surgery, because one of the surgeons there was one of the premier developers of that technique. And some patients, if they have too much skin overhang, it's just not possible. But if you have decent thick skin and not too much overhang and just a larger breast, a lot of times I can avoid that under the breast.
So it takes you a lot more time, by the way. I mean, this is
it does.
Kind of a surgery.
It does. It takes multiple hours, and I'm doing all the stitching myself and making sure everything looks as nice as possible. And once again, sitting the patients up, making sure that the symmetry is good, making adjustments, just trying to give them the best possible result.
What should somebody look for then in a surgeon that's going to do a reduction surgery?
Well, I think obviously they need to be a board-certified plastic surgeon. You need to make sure they've done a lot of this type of surgery, and you need to make sure that when they do the surgery, they're paying a lot of attention to the detail. Are they getting a lot of boxy, square-looking breasts? Do they have a lot of nipples that are way too high or too low, or breasts that still look a little bit droopy? Look at photos, look at lots of before and afters, and see what's the quality of the surgeon's work and what can I expect.
How important is frequency, by the way, that you do a lot of these?
I think it's really important. I don't think you have to be doing 10 breast reductions a day to be good at it, but you have to be doing it on a fairly consistent basis so you can understand what works, what doesn't work, and there's a wide array of patients that you'll see who need breast reduction. Some need a lot of reduction, some need a little, and the skin quality can be dramatically different. So the more experience a surgeon has with a technique, in general, the better they're going to do. But you also need to, again, balance it out with what are their actual results. I mean, you can have somebody who's been operating for 40 years, but if they do a not such a nice result every time, I guess that doesn't help either.
I guess the last category, reduce.
Right.
You do a lot of that.
I do a fair amount of revision surgery. I think if you're a very busy surgeon doing a lot of breast surgery, you're going to see a lot of revisions where patients are coming in wanting problems corrected from other prior breast surgeries. What are those
problems, by the way? I mean, when should somebody go in and say, okay, now it's time to get a redo or a revision?
Ultimately, if they're not happy with how their breasts are looking, if the breasts have stretched out over time, or if they were never looking good in the first place, those are the kind of reasons where you should at least get a consultation and see how things are doing. I think that breast surgery in general, the techniques for corrective surgery are some of the most difficult. I'm putting techniques that I use from my lift surgeries, from my augmentation surgeries, all these different things together to try to fix these problems. Sometimes I'm bringing in other materials that I use internally to help pad and reshape the breast pocket. So, for me, the corrective surgery improves my techniques for all my other breast surgery because it's by far the most challenging, and it's basically a level above what I do with regular, straightforward first-time patients.
Okay, and hardening of the breast, you could take care of that.
Yeah,
is that a big part of the.
Yeah, absolutely. It's not that common. In general, it's probably maybe 4 or 5% of patients will have some problem, at least in my experience. But those patients can have a very tight, unnatural breast. The good news is it's extremely fixable, and you take that scar tissue out, you replace the implant, and in some cases I use this acellular dermal matrix, which is a special material I put in there that seriously reduces the risk of a recurrence. I can get patients with very, very hard, weird, unnatural-looking breasts to very beautiful breasts. I think the best thing to do is look through pictures. On my website I have examples of corrective breast surgery, huge array of problems, huge array of solutions, and patients can see that for every problem there's something I can do to fix things up. And usually when people come in for regular breast surgery, they'll say, hey, I saw the stuff you were doing on the corrective section, and if you can do that, I know you can do a good job on my first time surgery. They understand it's if you're fixing those kind of problems, you're going to be good at all the more straightforward surgeries.
So good, it's a big boost in their self-esteem.
I think so, yeah.
You see changes, huge changes.
I have patients who have this corrective surgery, and afterwards they'll say, how could I have lived with these breasts for 15 years? I couldn't even sleep on my stomach. I couldn't give people hugs because my breasts were hard, or I was so embarrassed I couldn't wear a bathing suit. And after the surgery, they have soft, natural, normal-looking breasts again, and they just it's a life changer for a lot of them.
Okay, good. So that's where it begins.
Yeah,
go in for a consult. Know your options.
Yeah, every breast is unique. Every patient has 2 different breasts, so you need to see the surgeon, and they need to really give you a very detailed evaluation, examination of your breast to get you the best possible result, depending on what your issues are.
And you're always trying for perfect, you say.
You never hit perfect. As
but
a
you
human,
say you're trying for perfect. You told me on the phone.
I try to get as close to perfect as I possibly can.
You tell that to your patients?
Yeah, I always tell them, there's no such thing as perfect, but I will do my best to get the best looking breast I can for you.
And you are, let's see, obsessive compulsive about this stuff.
I think my wife would agree. I can be a little bit obsessive compulsive about certain things. Certainly my staff know that too. I just try, I can't help myself. I always try to get the best result I can, even if it takes me a little bit longer to do it.
You also told me that good enough is not good enough for you.
No, not in general. Good enough is not something that is really in my vocabulary. I always have to feel at the end of surgery that I've done as good a job as I could possibly do on that patient.
Okay, good. Well, thank you for coming. Very interesting.
Thank you very much.
You've been watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. If you would like to see this interview again online, you can visit our website at wellnesshour.com. Just put in Dr. Cohen or breast surgery. For now, I wish you good health.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez.